also useful to use as a kind of new surrogate endpoint for clinical trials, and we all now rely, and the regulatory authorities want that, rely on survival endpoints, and that takes a long time before you get an answer if a new drug is useful or not. The example is the FLT3 inhibitor, midostaurin. It took, I think, 8 or 9 years before it became clear that there was a survival benefit by adding midostaurin to standard chemotherapy. And I think when you measure MRD, you can much faster decide whether a drug will be successful or not. It's certainly not accepted as an endpoint by the authorities, but they are really interested in that, and we are working with the authorities to get it in a place so that MRD in the future can be used as a surrogate endpoint and leads to further and faster drug approval. So that's a really useful development, I think. Difficulty with MRD is that it's not a really standardized method. The molecular quantitative PCR is more or less, but the flow is certainly not standardized, and we are in the process in the European Leukemia Net to come to some recommendations for harmonization of especially flow and the molecular also. But the molecular is less difficult, the flow is the difficult part, but I think we made great progress in the past year. We gathered together quite a number of experts from both sides of the oceans, from Europe and US, to come to guidelines that will harmonize the way how and when and how to apply minimal residual disease.